Good afternoon. Welcome back. I'm Erik Schabert, DO, and I'm very excited to have all of you here. I have a great topic this afternoon that I would like to talk about, and that is some new information, well, relatively new information, in better approaches to management of diabetes. So, the first thing I want to talk about, because I'm going to be the little bit of the medical nerd I am in trying to get this information out, and I want to talk about the types of diabetes. Broadly, there are two classes of diabetes, type 1 and type 2. The difference is pretty simple. In type 1 diabetes, the primary problem is that some kind of immune attack or some other damage has occurred to the pancreas, and that individual doesn't make insulin the way they should anymore. And with that deficiency of insulin, blood sugars go up because insulin is the primary hormone that allows our cells to take insulin in and use, or to take, blood sugar in and use it for energy. So in type 2 diabetes, we have a different problem. In type 2 diabetes, we have seen a rise in insulin resistance, which means we're still making plenty of insulin, but when it binds to the receptors on our cells that should get us to take sugar in, that doesn't happen anymore, at least not the way it should. So from there, I'd like to start to talk about a study called the EDICT study, published by a group of researchers led by a doctor by the name of Ralph DeFronzo. Dr. DeFronzo has long been seen as one of the top medical investigators in the realm of diabetes, and he is, at least in part, responsible for our understanding of all the different bad things that happen when type 2 diabetes progresses that cause blood sugars to go up and stay up. The results of this study are a big deal because type 2 diabetes is a huge problem in the United States on multiple levels. Number one, the incidence is very much on the rise. We are seeing more and more type 2 diabetics, and we're seeing people become diabetic at a younger and younger age. And this is a massive problem on a number of levels. First off, recent data that I've seen is estimating that we spend $245 billion a year on the treatment of diabetes in the United States. And we have 28 million diabetics. That's almost a tenth of our population is diabetic. So this is a massive problem, especially when you consider individuals with diabetes, particularly uncontrolled diabetes, are prone to a myriad of problems that cause a lot of morbidity, we call it in medicine, a lot of damage to individuals, a lot of problems that interfere with their life. And these include heart attacks, strokes, kidney failure, liver damage and liver failure, peripheral vascular disease leading to amputations, and blindness. Obviously, these are things we want to avoid, and we can avoid them by instituting regimens very early in the course of diabetes that can prevent the progression of the disease and what we call end organ damage, which is basically all of those nasty things that I just talked about. So the first step is making sure we are diagnosing diabetes as early as possible. And in that, we physicians in the medical community in the United States need the help of all of you out there. What that means is we need you to go to a doctor and get checked periodically, particularly if you have a family history of diabetes or you have the most common of the early symptoms of diabetes, which is excessive thirst and having to go to the bathroom more frequently all of a sudden. So, and obviously you're at greater risk if you're overweight. In any case, once diagnosed, we need to know what do we do for someone once they have the diagnosis of diabetes to get the best outcomes possible. So that's where the EDICT study and Dr. Ralph DeFronzo come in. This information is not entirely new. The EDICT study was originally published in 2015, and a 6-year follow-up on the initial study was collected in 2018. But all of this information was just presented at a major medical conference earlier this year, which brought it back into the spotlight and put it on my radar. I think this is important information. Traditionally, the way we have treated diabetes and the recommendations from the American Diabetic Association that most physicians follow is to start a patient on metformin when they are first diagnosed and titrate the dose of metformin up until things are controlled, or if once reaching the max tolerated dose, blood sugars are not controlled, we add on a type of medication called a sulfonylurea. This type of medication just really causes the pancreas to secrete additional insulin, whereas metformin improves insulin resistance in the liver. If that combination is unsuccessful at controlling blood sugars, the recommendation is to add insulin. And there are a variety of possible insulin regimens that can be used. They necessitate checking blood sugars a little more regularly to get the dose correct. But that is the regimen that we have traditionally used. This approach has a couple of downsides. First off, of all the bad changes that occur in the human body in type 2 diabetes that cause blood sugars to elevate, this is really only addressing one of those. And the sulfonylurea and insulin component of this approach don't address any. They are simply putting more insulin on board to overcome the insulin resistance that goes with diabetes. And what we have traditionally seen is too frequently patients' control goes, while we are initially able to control blood sugars, that is, over time, we lose that ability and blood sugars creep up and up and up. And this approach just isn't that effective at getting a large number of people to control. Dr. DeFranzo, being one of the people who came up with the research that showed all these different problems that happen in the human body that cause blood sugars to go up, he had the thought of attempting to use a regimen that addressed a large number of these and do that right from the get-go with newly diagnosed diabetics and compare it to this traditional approach. That's what the EDICT study is. And so what he did was he started the patients in the treatment arm of the study, the new treatment arm, on a combination of a medication called exenatide, which is the first of a very commonly used class of medications called GLP-1 agonists. Some medications you might heard of that are more recent additions to this class are Ozempic and Mounjaro. But the first one was exenatide under the brand name Byetta. So he's using exenatide with metformin and a medication called pioglitazone, which is an insulin sensitizer peripherally in the muscle. So by using that 3 medication combination, he's addressing 7 of the 8 things that go wrong in diabetes that cause blood sugars to elevate. So let's talk about the results. At the 6-year point, in a follow-up on all the data in this study, we saw some fairly extraordinary differences. There was a major difference in the mean hemoglobin A1C, which is one of the really common measures by which we monitor how effective our control of a diabetic's blood sugars are, because they're a great indication of a 3-month average of what the blood sugars have been during that period. So what we saw was in the triple therapy group, they had a hemoglobin A1C, an average hemoglobin A1C of 5.8 versus 6.7 in the metformin sulfonylurea insulin group. Additionally, we saw a much higher percentage of patients in the triple therapy group getting their A1C below the surveys or the trial's target goal of 6.5. 52% in the triple therapy group hit that goal, while only 25% in the insulin group hit that goal. Additionally, we saw a 1.2 kilo average weight loss in the triple therapy group, as opposed to a 4.1 kilo weight gain in the insulin group. we all know weight gain is the enemy of blood sugar control in diabetes. So seeing weight loss versus weight gain is definitely significant. Additionally, we saw much better beta cell function through insulin clamp studies in the triple therapy group. This is an indication that with triple therapy, we are preventing the progression of every part of the diabetic pathway, whereas we're not doing that with our traditional approach. Additionally, we also evaluated these patients for fat deposition in the liver and increased thickening of their carotid arteries. The thickness of the carotid arteries is a good analog for overall atherosclerosis. That is the process that leads to heart attacks and strokes, amongst many other complications. And what we saw was a much less of a progression in increased thickness of the artery walls in the triple therapy group. And it was a rather marked difference. And we also saw that they had less fat deposition and scarring in the liver. Again, this is extremely significant because these are the kinds of outcomes that really show us that this triple therapy approach was superior. Okay, so I'm going to talk a little bit more about what the evaluations by the medical community have been of this study. First off, it should be noted it was a relatively small study. They were doing such extraordinary monitoring of the individuals in both of the trial groups that it really wasn't possible to do this with more than the 220 or so patients that they had split up between the two groups. Some evaluators of the results of this study have used that to attack it a little bit, saying that its numbers were a little too small to draw definitive conclusions from. I disagree because of the quality of the monitoring. Additionally, it should be noted that the drugs that were used in the triple therapy group are all older drugs and probably not the ideal combination for maximum effect. To get that ideal combination, I would substitute tirzepatide for exenatide and getting a more effective GLP-1 analog on board. And I also would replace the metformin with an SGLT2 inhibitor like Avandia, or like Jardiance, excuse me, not Avandia. So that would actually allow us to address all 8 of the defects that occur in diabetes, and also would give us more potential for weight loss. In any case, the regimen that was used was extraordinarily effective. And the best part of it is, if you are paying out of pocket without insurance for those 3 drugs, you're probably looking at less than $5 a month in the United States right now. That makes this a very accessible treatment regimen. What I would like to see is a much higher percentage of newly diagnosed diabetics in the United States, and elsewhere for that matter, being evaluated for the appropriateness of this type of therapy approach. It isn't going to be right for every newly diagnosed diabetic, but it will be right for a lot of them. And I think we can get much better long-term outcomes by leveraging this kind of approach a lot more. So if you or someone you love is a newly diagnosed diabetic, please bring in some of this information. Ask them about the EDICT study and if the type of therapeutic approach they saw there would be appropriate for you or your loved one. I think we really can start to cut down on that massive multi-billion-dollar cost of treatment of diabetes, since so much of it is about treating the complications of it. So if we can get a little more effective on treating it, we can prevent a lot of heart attacks, a lot of strokes, a lot of kidney failure, and a lot of grief for people we care about. Thanks so much for coming in and checking me out today. Please do remember to like, subscribe, and comment if you can. Sharing this with other people also helps a ton to get the information out. Thank you so much, and we'll see you next time. Please do remember the information presented on this channel is really intended for you to take to your physician in your area and discuss for definitive advice. This is not intended to be medical advice. This channel and its contents do not constitute the practice of medicine and in no way imply a doctor-physician relationship. Thanks again for tuning in, and we'll see you in the next video.